I'll turn my microphone on and call the hearing to order. We're pleased to have all of you with us today, and certainly another distinguished panel for this hearing. Let me tell you at the outset that this is one of those days where we have a lot of votes on the floor. In fact, we're going to be interrupted almost at the point we begin today with a series of about 10 votes of amendments that were debated yesterday and will be on the floor for an immediate vote this morning. We thought we would try to get started and call the committee hearing to order and get a few maybe opening statements before we have to leave. We will try to accommodate your time constraints because you are our guest and we appreciate your presence with us today. We also have a great deal of interest in the subject matter of this hearing and in the testimony that's going to be presented. We will have several members of the full committee who are not members of our health subcommittee who will probably be joining us, and I invite them to join us on the dais. For them, will say that they are entitled to, I would ask unanimous consent for them to be allowed to submit their written statements for the record, and without objection, that is so ordered. There may come a time in the questioning stage where, depending on how long we have been going in this hearing and the availability of time, that we will address the issue of their ability to ask questions at that point in the hearing process. We would certainly at this point ask unanimous consent for those members of the full committee to be allowed to submit written questions for the record in the event time does not allow their oral questions. And without objection, that is ordered. Well, I'll recognize myself for an opening statement. As I said, we are pleased to have such a distinguished panel of guests today with us and look forward to your testimony on a subject that I think is certainly at the very top of most people's concerns when we talk about health care reform. The use of better information technology in health care holds the potential not only to save lives but also money. And the creation of an electric system to track medical records hopefully will reduce medical errors and help eliminate inefficiencies and waste in the current system. These systems hold the potential to significantly improve health care by eliminating illegible handwritten prescriptions, providing immediate access to laboratory test results, and making a patient's full medical history available to their treating physician, no matter where that patient may seek treatment. As many of you are aware, several bills have already been introduced in Congress to deal with this general subject matter of new technologies. These proposals reflect a broad range of ideas about what can be done to create the proper incentives to encourage more health care providers to acquire and use health care information technology. This hearing is hopefully going to be the first in a series of hearings to explain these proposals and explore what actions Congress needs to take in this area. However, we need to be cautious of dramatic legislative proposals which largely seek to regulate this budding technology area. Innovators, investors, healthcare providers, healthcare payment systems, and patients will drive these changes. As a guiding principle, Congress should do nothing that would impede or limit reforms which are already transforming the marketplace. The President and the Health and Human Services Secretary, Michael Leavitt, have both shown broad leadership in promoting this great discussion and demonstrations and initial activities that hopefully will be helpful to our future. We're also seeing many hospitals, physicians, pharmacies, and payers moving forward in the implementation of this technology. We neither want to interfere with this effort nor overstate the government's role in innovations, applications, or basic investment decisions. Ultimately, investments in the products, training, and activities to promote the use of structured information will happen piece by piece and not by a grand government design. We must also continue to provide patients with the assurance that their personal medical records will remain private and not be subject to inappropriate disclosures. Such protections must also balance the need to be realistic and workable so that patients can reap the benefits of better health care through the use of IT. The adoption of new technologies holds the potential to improve accountability and empower patients with greater access to their own medical records. At the same time, safeguards must be provided to prevent hackers and other unauthorized persons from gaining access to confidential medical records. As we move forward, let's look at the many legislative proposals to promote electronic health records of health information technology in a cautious fashion. Hopefully, we in Congress can be helpful and not unintentionally slow down or misdirect the growth in the many new innovations and applications to come. Again, I welcome our witnesses and thank you for your participation. And in the absence of Mr. Brown, I'm going to recognize Mr. Waxman for an opening statement.
Thank you, Mr. Chairman, and I appreciate your holding this hearing. It's an important issue. As we look forward to electronic health records and promoting smarter information systems, I want to raise the same caution that you just did as well. Computerized medical records pose a threat to one of the most basic privacy rights that an individual can have. Basic medical and genetic information should not be shared without meaningful informed consent. But even with consent, protections against release of information, the right to be informed of any breach of privacy, the right to have access to one's own information, and strong protections against the discriminatory use of the information are all critical. Further, the maintenance of state laws to protect privacy should be a bedrock principle. We cannot take such comfort in our federal rules that we can afford to eliminate any additional protections. And finally, I can't help but comment on the irony that we would even contemplate limiting state protections when we have so clearly failed at the federal level to adopt legislation that assures basic protections against discrimination on the basis of genetic information. This committee has jurisdiction in this area, and it should exercise it. It's an important one to keep in mind. As we look at the positive side, we should also recognize that there is a potential negative side to this new computerized health world. Thank you, and I yield back the balance of my time.
Mr. Shattuck, you're recognized for an opening statement.
Thank you, Mr. Chairman, and I want to compliment you on the legislation you've put in this area. I would echo the remarks you made in your opening statement. I will not make my own opening statement other than to say that while there are important gains that can be made in this area, my personal belief is we ought to also be looking at giving consumers more choice. Choice works in so many other places, and in the healthcare field, we have given consumers virtually no choice. Their health care plan is selected by their employer in the vast majority of cases. It's handed to them from that, their doctor. They are told who their doctor is in any given area. And I believe we have taken them too much out of the equation and that it is critical. While the kinds of gains that we can make here are very important and need to be pursued, and I compliment the bill you have, we also need to be looking at advancing choice in health care to the greatest degree possible. With that, I yield back.
I thank the gentleman. Ms. Capps, you're recognized for an opening statement.
Thank you, Mr. Chairman, and I want to thank you also. I'm pleased that we're holding hearings on health information technology because I believe that facilitating better sharing of information between members of the healthcare community is a very important aspect of improving patient safety and quality of care. I'm very excited to hear from our witnesses today, and I thank you, each of you, for coming. I'm excited by the prospect of eliminating unnecessary procedures and duplication of examinations or lab work that is often caused because of the inadequate filing and information transfer. I am optimistic about how utilizing health information technology has the possibility of removing many of the administrative burdens that healthcare professionals, especially nurses, must devote their time to. I'm thinking of the people who are carrying the burden of delivery of care within our institutions and settings, and the time that is so often taken away from the patient to fill out duplicative records, and each time that is done, it makes the possibility of error creep in. As we all know, the current nursing shortage crisis is only continuing to worsen. Less time spent filling out paperwork, as I said, or combing through extensive medical histories means that nurses and other patient care providers can spend more time with their patients. That's going to mean better health care for patients. I'm also interested in how health information technology has the potential to reduce costly, often fatal medical errors, such as adverse drug interactions. The prospects for expanding the use of current information technology extend far beyond how we treat current patients also. Finally, I'm hopeful about how digitalizing records may help serve the medical research community as long as the privacy protections are maintained, and that's a big as long as. But I think the possibility exists for doing this, and I want us to explore the ways that technology can help us with the privacy protections as well as accessing medical research, which is imperative for future developments in healthcare. As we work to reap the potential benefits of health IT, we will face challenging challenges in developing a method that is cost-effective and accessible to all providers. Furthermore, while evaluating the different paths toward increasing the usage and improving the interoperability of health IT, we must remain concerned, as I said, about protecting patient privacy. As always, expanding the use of information technology systems lends itself to greater access of information in both positive and negative ways. We must ensure safeguards are in place to protect sensitive information from being accessed by the wrong parties or being used to discriminate against individuals. So I look forward to hearing from our witnesses today on how we can create a system that is beneficial to everyone involved in the provision of health care, keeping that our bottom line, to improve patient treatment and protect patient privacy. I yield back the balance of my time.
I thank the gentlelady. Pleased to recognize my friend, Mr. Brown, the ranking member of the Health Subcommittee.
Thank you, Mr. Chairman. I apologize for being late. Thank the witnesses, all of you, for joining us today. We've all heard the statistics. According to the Institute of Medicine report, to err is human. Studies have found that deaths from medical errors range from estimates of 44,000 a year to as high as 98,000. Among the reasons cited in the report for such extremely high numbers of errors are issues like illegible writing in medical records and the lack of coordination and communication across providers. I'm pleased the committee has called this hearing today because increased use of electronic medical records is a very promising means by which to address these errors, cut down on the number of unnecessary deaths in this country, as well as improve the quality of health care. Electronic medical records provide the ability to coordinate care across different health care sites. This means your general practitioner can keep track of what treatments you're receiving from different specialists, helping oversee your care, make sure you get the services that you need. They can reduce healthcare administrative costs as duplicate folders of paper records are consolidated into one electronic record accessible from any computer in the office. Hospitals and doctors' offices can establish support systems for their doctors to help them make the best decisions for their patients. Right at the bedside, doctors can check for patient allergies and whether they have a family history of stroke, for example. According to the IOM, health information technology is a key step to improving the quality of health care. Finally, electronic medical records means that records can travel with patients backed up in case of emergencies. Katrina highlighted this point clearly. In the wake of the hurricane, thousands of displaced individuals with serious medical conditions found themselves with no access to their medical records. Paper records in doctors' offices were unreachable or, in many cases, were destroyed. Patients had no record of what medications they had been taking, what dosage, what treatments they were receiving, whether these treatments had been effective or not. Breaks in care can be deadly for individuals with health conditions like some forms of cancer or HIV/AIDS that require ongoing and regular treatment. In a system of paper records stored on shelves in doctors' offices, displaced residents found themselves having to try and recreate years of medical records. In circumstances like these, electronic medical records can actually protect patients' health by allowing doctors to immediately identify health care needs and provide treatment in a timely manner. I do want to be clear, however, that while there are many benefits to increased implementation of health information technology, we have to be very cautious about how we move forward. Over time, these systems may result in savings for providers and for patients. Their development and implementation is a costly process, one that can be a heavy burden for family physicians and their practices. We should never mandate the implementation of costly technology without adequate support, particularly for small physician practices that may not have the necessary capital. Finally, there must be adequate protections for patient privacy. We've all read the stories about stolen bank records in the last few months. Imagine the cases of stolen medical records. My own state of Ohio has enacted a series of laws expressly aimed at protecting a patient's confidentiality, a patient's ability to determine with whom and how medical information is shared, and a right of action in cases of inappropriate disclosure. In particular, the state has enacted laws protecting information concerning birth defects, HIV/AIDS, and genetic tests. These are important protections. The last thing we want to do is see an individual avoiding necessary and important medical care for fear of a lack of confidentiality. We need to put resources in developing standards and guidance to assist physicians and medical institutions through the process of developing electronic medical record systems. However, we have to be keenly aware of finding an appropriate balance between utilizing technology and protecting patients. I look forward to hearing from all of our witnesses about how to address these issues. Thank you, Mr. Chairman.
Thank you, gentlemen. Recognize Dr. Burgess from Texas, a member of our subcommittee. for an opening statement.
Thank you, Mr. Chairman. I appreciate you calling this this hearing today. I do have an opening statement I'll submit for the record, but just like to make a few observations. A few years ago in a graduate level course that I took so that I'd be better able to understand the business world as I practice medicine, I learned a startling fact that the insurance industry spent between 7 and 12% of their budget on information technology. The average small office, such as mine, spent an average of 1 to 3%. Clearly, we could not keep up at that rate. We had an opportunity in this country with the Y2K. Most people don't remember that now, but it was a big deal in the health industry for a time. And I used that opportunity to upgrade the computer services in my office over the objection of my partners because it didn't really return any real value. And it is going to be a process of educating physicians, particularly physicians my age who didn't grow up in the computer world to recognize what that value is. But that brings me to another point. It's not really related to this discussion this morning, but it is important, and that we are faced with the prospect of continually cutting Medicare reimbursement for physicians year over year under the SGR formula. And Mr. Chairman, we've got to seriously deal with that because we are going to drive out the best and brightest physicians, and when I'm referring to physicians my age, the 40 to 50-year-old doctor is going to be driven away from the Medicare system. And if we're going to spend all of this money, all of this investment in information technology, you want to keep your best and brightest involved in the field. So people have said we can't tackle it this year. It's just too big a bite, but I submit that there's no better time than the present to do that. The ranking member brought up health privacy issues with HIV and birth defects. As we move into the genomics age, that's going to become even more critical, and we have to be able to assure people, the public, that their medical information will be private and not readily dispersible across half of the civilized world. And then finally, Mr. Chairman, I just have this observation. In the 21st century, it almost makes no sense that we stovepipe things the way we do here in Congress. And while I appreciate you having this hearing here this morning, to me it just underscores that there is no Committee on Health in the United States Congress. Our jurisdiction is divvied up between several committees, and I think it's time for the Committee on Energy and Commerce to assert its rightful place and take all of that jurisdiction so we can deal with these problems without having to go through stovepipes. With that, I'll yield back.
I thank the gentleman. Another member from Texas, Mr. Green, is recognized for an opening statement.
Thank you, Mr. Chairman, for holding a hearing on electronic health records and legislation introduced by our colleagues to facilitate further development of health information. I'd like my full statement to be placed in the record, and I'll just talk about two incidences that recently. When we had Hurricane Katrina and Rita, Katrina in Louisiana and obviously Rita in southeast Texas and southwest Louisiana, there was a couple of events that I think can show how important electronic records were. As both hurricanes approached the area, and everyone fled, including a lot of our healthcare providers who closed the facilities. In a time they had to figure out how they're going to store their records. The benefit of electronic records is incalculable for providers who had them in place. In Beaumont, Texas, a 19-doctor practice knew that Rita was coming and backed up their computer data with a server in a Dallas hotel room. And a week after Rita hit, the practice reopened, and all their data, including their patients' electronic records, were there, and it reappeared if nothing happened. The hurricanes were also highlighted the need for interoperable within the EHRs. In my hometown of Houston, where we received 150,000 residents from New Orleans, it was so chaotic to try and have people come in and get them re-diagnosed that didn't have their medication. You didn't know what dosage. But the VA stood out. If we received a veteran from Louisiana, the VA medical professionals at Houston's VA's medical hospital were able to access the records for these evacuees who had typically received care at the VA hospital in Louisiana. Mr. Chairman, that shows in the real world, particularly in an emergency situation, disaster, how this can be done. And I think we need to do, I know it's costly, but the further we move it along, the better it will be, not only for, I think, the physicians who practice, for their sanctity of their records, along with our privacy concerns, but also for the delivery of medicine to our constituents. Thank you.
Thank the gentleman. Ms. Baldwin, you're recognized for an opening statement.
Thank you, Mr. Chairman. I'm happy that we're taking this time to focus on healthcare IT. Like other members who have spoken already this morning, I want to add my voice of support for implementation of healthcare IT. It's the healthcare topic that policymakers love to love these days. And it's easy to understand why healthcare IT is so popular. The potential for improving patient care, making better use of scarce resources, and collecting data for research is huge. Imagine the opportunities for medical collaboration that healthcare IT could provide for a rural doctor who needed to consult with a specialist who was hundreds, perhaps even thousands of miles away. Or imagine the immensely powerful research data that could be de-identified and then analyzed to track the spread of avian flu or widespread negative side effects of a popular drug. So I'm encouraged that we're taking up this important topic, and I hope that we'll be able to have some constructive discussions on issues involving advancing healthcare IT. But I also think we need to be very upfront and clear about the issues involved and the potential pitfalls. From a provider standpoint, there are many barriers to the adoption of healthcare IT. These barriers may be financial, technical, cultural, or legal, and these are all worthy of serious consideration. Discussing only the interoperability or the interconnectivity issue could take us hours to fully understand and perhaps years to reach agreement on. From the patient perspective, while patients stand to have enormous potential gains from increased access to and, frankly, ownership of their own health records, there are also potential pitfalls, specifically surrounding how to craft a healthcare IT system that ensures patient privacy protections are not sacrificed in the name of increased efficiency. Lastly, I think we need to be very cognizant of avoiding the situation where we have healthcare IT haves and have-nots. Healthcare IT systems are expensive, and those who spend the money to put healthcare IT systems into place are not always the same people who benefit from these systems. So we need to keep moving forward, keeping this in mind, and looking for ways to bring responsible, privacy-protecting healthcare IT systems to all Americans. Thank you, Mr. Chairman, for holding this hearing.
Thank the gentlelady. And Mr. Gonzalez, a member of the full committee, we welcome him to the dais as well, and thank you for being here. It's my pleasure now to introduce our distinguished panel, and we are just about to be interrupted with these votes, but I'll try to get your introductions in before that time. First of all, Mr. Ivo Nelson, healthcare industry leader with IBM. Dr. William Braithwaite, who is the Chief Clinical Officer of eHealth Initiative and Foundation for eHealth Initiative. Mr. Alan Mertz, the President of American Clinical Laboratory Association. Mr. Bill Vaughan, Senior Policy Analyst at Consumers Union. Mr. Mark Neaman, President and CEO, Evanston Northwest Healthcare. Mr. James C. Pyles, attorney and member of a firm here in Washington, D.C., and Dr. Don Detmer, President and Chief Executive Officer of American Medical Informatics Association in Maryland. Gentlemen, we are pleased to have you here, and how about that for timing? We will let the buzzer ring for its required period of time here, and we got 5 more buzzers to go, and they'll start in just a second. But Mr. Nelson, we will at least try to get your opening statement in. Let's wait for these bells to ring again. I think they'll be, I know my bells.
We could use a little technology.
That's right. Mr. Nelson, you may proceed.
Thank you, Chairman Deal and members of the subcommittee. My name is Ivo Nelson. I'm actually here from Texas, so I feel quite at home with the people that are here today. I do lead the IBM Healthcare Business Consulting Services Group. IBM appreciates this opportunity to testify in support of legislative proposals to promote electronic health records in a smarter health information system. Today, there's growing consensus that a more intelligent, innovative healthcare system is within reach through better use of information technology. The IBM Corporation is fully committed to helping a smarter health system emerge as a model of 21st century American innovation. One of IBM's core values, creating innovation that matters to the company and to the world, today almost everyone agrees that dramatically improving healthcare is the innovation that matters. To that end, we are collaborating with other large employers, agencies, providers, and standards bodies to transform healthcare. Today, it is a fragmented, paper-based problem. Soon it will become a highly connected system for fluid exchange of digital health information and innovative new services. As a company, we are striving to do for healthcare what the ATM system, which we helped to invent, did to launch a global infrastructure for electronic financial transactions, or what the Internet browser did to catapult the web from an academic network into the platform for innovation it is today. With respect to pending legislation proposals, IBM supports provisions that serve three objectives: drive adoption of open standards by the federal government and private industry, commit initial seed funding, and make early policy choices, create incentives in Medicaid and Medicare to reward quality of care. These three areas are keys, we believe, to a smarter system of health. This new model of care will unlock the value of health information and help health care become properly organized around its core constituents, patients. Let me expand briefly on the three topics I've outlined. Standards and interoperability are the front and center in a project called the Nationwide Health Information Network, or NAHIN. IBM is one of 4 companies developing prototype architectures through a contract awarded in 2005 by the Office of the National Coordinator of Health IT at the Department of Health and Human Services. The NAHIN project can be thought of as a foundation for a medical internet and digital infrastructure for healthcare. It was also structured with the ingenious requirement the 4 contractors must make their respective efforts interoperate with each other via open standards. The success of the internet itself is overwhelmingly due to open standards and protocols such as HTML, XML, IP, and many others. Some healthcare standards have had long use within care settings, and new standards are emerging. What's needed today is to expand the use of these standards across multiple care settings and across all of government healthcare. Federal adoption of an open standard for these core elements of medical is critical. For example, federal agencies mandate reporting of extensive amounts of clinical information, yet don't allow information to be submitted via standardized electronic formats. I've actually attached FDA Drug Adverse Event Reporting Requirement, MEDRA, for you to take a look at. While this example is drawn from the FDA, each of the agencies has comparable examples of reporting that does not utilize health information technology built on standards. Turning to the government's role as an early funder and policymaker, history demonstrates that a new innovation often proceeds slowly at first before a catalytic inflection point causes it to accelerate. The Internet remains an obscure academic network for decades before browsers drove its explosive growth. With nearly half of healthcare spending in the U.S. originating with government, the public sector can have a decisive role in sparking a smarter health system for all of Americans. Committing initial seed funding and making early policy choices will set the stage for growth of health information exchange. The funding for Dr. Brailer's office and the National Coordinator and projects like NAHIN and PHRS are good examples of catalyzing funding. Efforts to resolve privacy issues are another. IBM hopes to play a complementary leadership role as an innovation partner for the business of healthcare and as a large employer providing healthcare to more than 500 million IBMers and their families. Finally, establishing electronic health records for millions of citizens will require a range of incentives to accelerate adoption, especially amongst physicians and providers. But the benefits of a smarter health system will enable a historic shift in medicine, one designed to reward outcomes and improve quality of care rather than today's fee-for-service model. Health IT is needed for this shift in reimbursement because it can ease the burden of measuring and reporting performance. Creating powerful incentives is necessary if we are to transform healthcare, and this committee can start by implementing pay-per-performance model in Medicaid. To summarize, the 3 points I leave you with are: the federal government can advance a smarter health system by widely deploying open standards. You can accelerate the transformation of healthcare through bold seed funding and active leadership in policy areas such as privacy. Strong incentives are needed to drive adoption of electronic health records and rewarding the quality of care in medicine, and Medicaid is one of the most powerful tools available. Mr. Chairman, members of the subcommittee, thank you for the opportunity to testify today. and I look forward to answering any questions you may have. I spend most of my time in the field with hospitals and payers, so I've got a very pragmatic view, I think, of the industry we're all operating in. Thank you.
Thank you, Mr. Nelson. And I again apologize, but we're going to stand in recess pending these votes. There will be 10, so we will probably be somewhere an hour or thereabouts before we will be able to get back. But hopefully we'll have a little better attendance perhaps after those first series of votes. Thank you, and we'll stand in recess.